have Dr. Robin Schaefer with us as well, because she is a breastfeeding expert. So I think many of us know Dr. Schaefer. She works with us on L&D in her capacity as a CNM, in addition to her roles in education in the School of Nursing and the medical school. If you look at all of the letters after her name, which are incredibly impressive, she also has her IBCLC, which for those who don't know what that is, that's the International Board of Certified Lactation Consultants. Dr. Schaefer was so gracious when she found out that I was giving this presentation that she actually reached out to me and asked if I wanted any assistance, which I gladly took her up on. And she provided a huge portion of the educational content that we're going to go over this morning. So big shout out to Dr. Schaefer. Thank you very much for your help. And she will be available for the Q&A at the end of the presentation if anybody has any questions that they want to direct towards her. I also want to thank some special guests that I know have joined us today for our grand round. So I know we have representatives from both pediatrics and family medicine who've also come to our talk today. So I just want to thank you for also attending. I don't have any other disclosures, financial or otherwise. So what are we going to do today? So first, we're going to talk a little bit about our breastfeeding rates at Robert Wood Johnson University Hospital across our health system and in the state of New Jersey. We're going to go over what I like to call some breastfeeding basics. And then we're really going to dive into the meat of the presentation, which are the evidence-based interventions for breastfeeding success and how we're going to implement some of these initiatives here at our hospital. So how are we doing right now? So here at Robert Wood Johnson University Hospital, our 2022 exclusive breast milk feeding rate was 11.67%. So what does that mean? You know, what is that number? So our exclusive breast milk feeding rate really is looking at healthy term newborns. So these are not babies that are going to the NICU. These are not preterm babies. These are also excluding some medical conditions that might be a contraindication to breastfeeding, or infants that are at particular risk for needing formula supplementation, like infants of diabetic moms. So these are your healthy, low risk pregnancy term newborns. And we're at, like I said, 11.67% for last year. And 6 months of the year last year, our rate was less than 10%. Our target, our goal, which is set for us by the Joint Commission, is 49.8%. So, you know, I think just looking at this slide at face value, most people would agree that we have some work to do and a ways to go. And how do we compare to other hospitals in the RWJ Barnabas Health System? Well, you know, quite honestly, not so favorably. So we're not totally last, although we just barely eke out NBI from being second to last. But you can see there are several hospitals in the system that are more successful than us. None of them actually also reached that Joint Commission target of 49.8%. But there are several hospitals in our system that are at 30% or above. And again, we are third from the bottom and have a lot of work to do. And how do we compare to the state of New Jersey, right? So this data is freely available. It's on the CDC website. It comes from the PRAMS data set, which is the Pregnancy Risk Assessment Monitoring System. There are actually tons and tons of charts and graphs you can look at if you're so interested, none of which is super great for New Jersey, I'll be honest. And, you know, if you look at table 1 in particular, initially I was looking at these numbers, you know, and New Jersey consistently is below the national average, but, you know, didn't seem so far off. I wasn't, you know, so discouraged just looking at the raw data. But I want to draw your attention to this last column, which is breastfed infants receiving formula before 2 days of age. So this is not exactly the same metric as the exclusive breast milk feeding rate, but it's similar in that it's looking at, you know, babies that are intending to breastfeed that receive formula before 2 days of age. And you can see that the national average here is 19.2%. New Jersey is at 25.2%, so definitely above national average. And when you compare that to what's going on in our hospital right now, so that means that in the state of New Jersey, about 25% of infants are receiving formula before 2 days of age. But at our particular hospital, 88% roughly of infants are receiving formula before hospital discharge, which is going to be in those first 2 to 3 days. And so we're pretty far off from what's going on at a state level in New Jersey. And then I started digging a little bit further into this report, and I found an even more sobering statistic, which, you know, me looking at the raw numbers and thinking, New Jersey doesn't look so bad. Actually, we are. So New Jersey is last in the country. We have the worst rate for this breastfed infants receiving formula before 2 days of age. And quite frankly, that was actually a very sobering thought. You know, us at Robert Wood Johnson are way off of the New Jersey average, and New Jersey is the worst in the country. And it definitely got me reflecting about what we need to do at our institution and really probably across our whole health system. And it also made me think a little bit about my Louisville Cardinals. So again, as Suzanne mentioned in the introduction, I'm from Kentucky, where college basketball is king. And even though I'm a graduate of the University of Kentucky, I am a diehard, indoctrinated from birth fan of the University of Louisville Cardinals. And this is actually a picture of me and my dad at a game during happier times in recent years. And people who know me well around the office may have noticed that I haven't really been talking about basketball much this season, and there's a good reason. It's because we're struggling. This year, our record is 2-19. We're 0-10 in the conference, last place in the ACC. So my Cardinals need a revamp. Our program needs a rejuvenation, and so does breastfeeding at Rutgers Robert Wood Johnson. And I have faith in both of our teams that we can turn the ship around. And who else cares about this? Not just me, and hopefully, and not just Robert Wood, but this is an initiative from the state of New Jersey, the New Jersey State Health Assessment data set, and the Healthy People Objectives are targeting breastfeeding rates with the 2020 goals actually being higher than what the Joint Commission sets for us in the 80 percentiles. And in September of 2022, the New Jersey Department of Health rolled out the New Jersey Breastfeeding Strategic Plan, which really is charging hospitals to help support families who want to breastfeed. They are giving us directives to maintain protocols for breastfeeding, to track our numbers, and to help our patients breastfeed if that is their feeding plan, and to promote breastfeeding in general. And so, you know, you might be sitting there as someone who takes care of moms or someone who takes care of babies, and you might be thinking, wow, those numbers are concerning and I'm worried about it. But Dr. Sweat-Patrick, I don't really know anything about breastfeeding. And that's not surprising, actually, and you're not alone. Part of the New Jersey Strategic Plan for Breastfeeding, they actually surveyed people who take care of moms and babies, care providers, nurse midwives, physicians, and physicians in particular. Only about half of physicians reported that they had received any significant training in breastfeeding or lactation in their medical school or their residency training. Our colleagues in nursing and nurse midwifery are doing much better in that area. Many more of them had formal training in this area. But if you're a care provider and you don't know much about breastfeeding, you're not alone. And that's why I decided to take a portion of the talk today to go over some breastfeeding basics. So we're going to talk about known benefits of breastfeeding. And because this is OBGYN grand rounds, I decided to start with the maternal benefits. And so we know that for people who breastfeed, right, there is decreased overall risk of breast, ovarian, and endometrial cancers, decreased lifetime risk of type 2 diabetes, decreased lifetime risk of hypertension and cardiovascular disease, which is actually an area of research that I would like to look into more in the future. There's also improvements in pregnancy spacing, right? So women who breastfeed for longer tend to have more time between pregnancies, lower healthcare costs, and you have less concerns about environmental safety and sustainability, right? You don't have to worry about formula shortages if you're able to provide all breast milk. And there are many, many documented neonatal and pediatric benefits of breastfeeding as well, right? So lower risks of infant mortality, lower risk of acute illnesses, lower risk of chronic illnesses, including type 1 and type 2 diabetes, some childhood cancers, asthma, eczema, and other improvements in neurodevelopmental outcomes and gut microbiome. I'm not really going to spend a ton of time talking about benefits of breastfeeding because I think those are pretty well established and accepted. And, what does the WHO say? So they say that breastfeeding is an unequaled way of providing ideal food for the healthy growth and development of infants. It is also an integral part of the reproductive process with important implications for the health of mothers. Okay, so I think it's important when you talk about breastfeeding and how breastfeeding works and how breast milk supply is established to understand these concepts before we think about some of the initiatives that we're going to discuss to assist in the effective initiation of breastfeeding, right? So the next few slides actually pulled from osmosis.org, which is on the AAP site if you're interested. It's actually about a 5-minute video. If you have time and you want to go back and watch the video, it's a really good video, but I'm going to give you the abridged version. Right, so first, what are breasts made out of? As OBGYN, I think the uterus is maybe my favorite body part, but breasts are also really cool. So they're made of fat and supportive structures, but when you're talking about feeding, right, there's glandular tissue and the lactiferous ducts, which go out to the nipple. The milk is actually made in alveolar cells, and the milk goes through the lactiferous ducts out the nipple to the baby, and that's how baby is going to get the milk. So what's going on during pregnancy and after delivery, right? So, during pregnancy, the placenta makes a hormone called placental lactogen, which along with prolactin, which is coming from the anterior pituitary, is going to stimulate growth and development of that glandular tissue. That's why our pregnant patients have, tender and swollen breasts during pregnancy, and that's the result of those hormones. Also during pregnancy, right, it's a very high progesterone state, and progesterone actually has an inhibitory effect on the release of milk. That's why most pregnant women don't start just freely lactating during pregnancy, because they have the inhibitory effect of progesterone. But once the baby, and more importantly, really the placenta, are delivered, there's a huge decrease in the amount of progesterone, which allows the milk to start to be released. So then you start thinking about, the milk ejection reflex, or what some people call letdown. So essentially what's happening here is when you put the baby to breast or stimulate the breast, there are mechanoreceptors in the breast, right? And they're going to send signals to your hypothalamus. And your hypothalamus is going to talk to your pituitary gland and tell your pituitary gland to release prolactin from the anterior pituitary, which is going to be acting on those alveolar cells to say, make milk. We need to make milk. There's a baby here. And oxytocin, right, from the posterior pituitary. And the oxytocin actually acts on these myoepithelial cells, which surround the lactiferous ducts. And that's what actually caused the milk to be ejected, or the milk to come out. And so really it is the stimulation from the baby that helps the milk ejection reflex and milk letdown to occur. And it's really important, early after delivery to start stimulating these receptors really as soon as possible to get this process going. And then you also have to consider both the endocrine and autocrine control phases of breastfeeding. So there's a couple of things going on here, right? So again, we just talked about if the baby is suckling or we're stimulating the breast, right? You're going to get the surge of prolactin and oxytocin from the anterior posterior pituitary to cause.
You're not going to work today?
To cause, the milk ejection reflex and milk letdown. But also what's happening is once there is milk in the alveolar cells, if there's milk that's just sitting there, that's not being removed, that actually has an inhibitory effect on the hypothalamus and subsequently the pituitary, which is going to tell your body not to keep making more milk because there's milk already sitting in the alveolar. And so it's really important, especially early, for frequent early feeds to happen, right? Because emptying those alveoli, emptying the breast, removing milk is going to stimulate more milk. Again, I'm going to say it one more time. Removing milk is going to stimulate more milk. That's why, you'll hear people talk about trying to have the baby feed every 2 to 3 hours or even more frequently in the newborn phase. Some people may use terms like 8 or more and 24 for number of feedings in the first few days of life. And really that is because, again, removing milk stimulates more milk production. So that's what's going to help your milk, quote unquote, come in. And let's talk a little bit about the milk, right? So there's a few different types of milk over time. I think many people are familiar that early, in the first couple of days after delivery, what you're expressing or what you're seeing is that colostrum. Some people call it liquid gold because it has that nice golden yellow color. And it's small in volume, and that's okay because baby's stomach at this time is also small in volume. So you don't need a ton of volume, but it's jam-packed with protein, immune cells, antibodies, lots of good stuff that are great for babies. And I'm always like championing my moms when I see them on postpartum, if they've got colostrum, that stuff is really awesome. It's liquid gold. But people worry, right? Because they want their milk to come in, right? And really what they're thinking about is this transitional milk, which has higher volume and more fat. And so it looks a little less yellow than colostrum, but it is not supposed to be there right away. So it's normal for transitional milk to come in anywhere from 2 to 5 days after birth. Sometimes it comes in a little sooner for moms who've had babies before. It can come in a little bit later in some instances, particularly in moms that have had like long labors or cesareans. And also it can be delayed if there's a delay in initiation of breastfeeding. So again, really important to try to get the baby to breast as soon as possible and continue to stimulate the breast because that's what's going to help your transitional milk come in. And the more mature milk doesn't actually come for a couple of weeks of feeding, well past when people are usually out of the hospital. So what are some normal newborn and maternal behaviors and breastfeeding behaviors after delivery? So newborns are kind of amazing. And, assuming you have a healthy newborn who's transitioning well to, ex utero life, if you just put mom and baby together pretty much right away, babies will actually seek out the breast and often attempt to suckle with really limited intervention. It's also important, for moms who might be breastfeeding or people taking care of breastfeeding pairs or dyads to know a little bit about infant feeding cues, right? So I said newborns eat a lot, and it can be helpful to be in tune with signs that they might be hungry or they might be ready to eat. And so some earlier signs that babies might be ready to eat, kind of rooting around, turning the head, smacking the lips together, bringing the hands or the fist to the mouth. If you wait until the babies are already, crying or pretty upset, they're probably pretty hungry at that point, and those are actually later hunger signs. One of the things we'll talk about a little bit later are things like nipples and pacifiers. And really, there's not necessarily anything inherently wrong with using soothing techniques or pacifiers, but you just have to be a little bit careful because sometimes you can mask some of these early infant feeding cues if you're relying on pacifiers a lot. What are some other, things to think about or potential concerns, things to keep in mind? So normal weight loss and gain for newborn infants. So it's really important to keep in mind that it's totally normal and expected for babies to lose weight after birth. Somewhere between 5 to 10% of weight loss is normal, and that's just diuresis. It's normal diuresis. And most infants will begin regaining weight by around day of life number 4. Now, again, for people in the hospital, it's good to remember a lot of our moms and babies are going home on day of life 2 or 3. And so it's okay if baby's not necessarily already regaining by hospital discharge day. And that's part of why the pediatricians see the babies so soon after hospital discharge to keep an eye on weight gain. And you would expect, if things are going well, for babies to regain their birth weight by about 2 weeks of life. Now, sometimes there is greater than normal or expected weight loss. It can be kind of variably defined. Some people use a criteria of, more than like 7 to 10% of loss in the first 48 hours or more than 75th percentile based on age and mode of birth. Again, these are indications maybe for more more evaluation, potentially for supplementation of formula or express milk, breast milk, or donor milk, but it doesn't necessarily mean that supplementation is required. There is some tools on the side that our colleagues in pediatrics use, and admittedly, I'm not a pediatrician, so I'm not an expert in this area, but it's good just to know that some weight loss after delivery is totally normal and expected. And you can, try to give your patients some anticipatory counseling about that. And, some signs that breastfeeding is going well, right? So day of life 1, uterine cramping with letdown, right? Because the milk ejection reflex is partially mediated by oxytocin. And I know all of my OB care providers, residents, and medical students know that oxytocin causes uterine contraction. So if you have your patient saying breastfeeding is going well, but gosh, I have really bad cramps, you should be telling them that that's actually a good sign and not necessarily something to be worried or concerned about. Over the next couple of days after life, you should start to notice some lightening of baby stool. So it'll go from that like black tarry meconium that, we're used to seeing right after delivery to by day, 5, 6 to that yellow, seedy kind of breast milk infant stool. You wouldn't expect moms to start really leaking significantly or having a lot of engorgement until, somewhere in like that day of life 3 to 5, right? Because that's when your transitional milk is starting to come in. And again, sometimes moms are worried that it's not happening, the first day. And that's okay. That's normal. That's expected. And like we said before, if things are going well, you would expect baby to regain birth weight by about 2 weeks of age. There are indications for formula supplementation in the first few days of life. So, one of the things I want to be really clear about is, when we talk about initiatives to support our families who want to breastfeed, what we're not saying is that we want to ban all formula or formula is inherently bad, because, those things are not true. And we know that there are medical indications for formula supplementation, and these are some of them, right? So if there's true like clinical evidence of insufficient intake, right? So if there's excessive weight loss, another thing that we'll often monitor is how many voids or stools babies have in a day. So if those are inadequate, if there are other just objective signs of dehydration, right? Urate crystals in the diaper, dry mucous membranes, then, supplementation may be indicated. Ideally, supplementation would be done with either expressed breast milk or donor breast milk, but if those are not available, then formula or human milk substitute is certainly acceptable. However, clinical situations where supplementation is not really indicated, there would be just a baby that's fussy or frequently feeding. Like that's normal. That's totally normal. You expect newborns to feed frequently. And actually it's really important, like I keep saying, to help with, the milk coming in and the milk ejection reflex. So, again, just anticipatory guidance, fussy infants, frequently feeding newborns, absolutely normal infant behavior. A mom who's tired or sleeping. Again, I've had a newborn. It's so hard. It's super exhausting. And, we can do other things certainly to help moms get rest. But if a mom is wanting a break and her goal is to breastfeed, I think it's on us to, explain to her that her going for a long stretch, whether it's a long nap or a long time overnight without feeding, is potentially going to delay lactogenesis and delay her milk coming in and may be counterproductive to her overall goal, right? And so, we can still take baby for short periods of time. We can give moms breaks. Absolutely. I'm not saying that we can't do that. But again, having a mom sleep through the night may give them, some initial benefit, but it might potentially cause long-term problems that they don't want to deal with later. So definitely a discussion to have with mom. Perceived insufficient milk supply. Like I said, we don't expect the transitional milk to be there right away. Colostrum is small volume and it's jam-packed with good stuff. So again, some anticipatory guidance there. And, just because you have a C-section is not a reason to give formula right away. And again, just management of, low breastfeeding self-efficacy, or basically moms having concerns or feeling worried about how breastfeeding is going or their milk coming in. A lot of it is just education, guidance, normalization of the experience, ongoing support, skin to skin, teaching them other strategies like hand expression and lactation support. A lot of guidance. I'm not going to spend a lot of time on this slide. There are some contraindications to breastfeeding and human milk feeding. Honestly, what I want people to take away from this is that there actually aren't that many contraindications. And most of these scenarios are relatively rare, with the exception of maybe HIV infection. The other plug I want to put in for this slide is that, most medications actually are not contraindicated in breastfeeding. And there are many resources that are readily available online or otherwise, where you can look up compatibility of medications and breastfeeding. So, it's a little bit lazy to say, I don't know if you can take this med and breastfeed. Maybe you should just pump and dump, or maybe you shouldn't breastfeed. Please take the time to look it up. And if you're not sure, honestly, I'm happy you can call me and I'll show you where to look it up. And I really wish that we could talk about so many more things for breastfeeding basics for providers who care for moms and babies, but we just do not have time today to go into the weeds here. So I put a couple of resources that you can use if you want to do some additional reading or self-directed education, because you could spend multiple ground rounds presentations on breastfeeding education. There's really so much to learn and do. But I'm going to switch now, and we're going to talk about the evidence-based approaches to successful breastfeeding and breastfeeding initiation. And you're going to hear some themes. You're going to hear me be repetitive a little bit over the next portion of the presentation. And I'll be honest, that's intentional, because I really want to drive some of these points home. But some of the key concepts to think about are that we really want to talk about dyad-centered, meaning mom and baby-centered, individualized care, a supportive environment free from unnecessary interventions, skin-to-skin contact. Skin-to-skin is huge. We're going to say skin-to-skin so many times. Physiologic breastfeeding initiation, right? So supporting those normal newborn and maternal behaviors. And then education and support, I'm going to say both from and for providers and staff, right? Because it goes both ways. And, from Dr. Schaefer, who's done a lot of work and contributed to the literature in breastfeeding, from one of her publications, we have some breastfeeding initiation key concepts. And I'm just going to go over those over the next couple of slides. So again, healthy term newborns have innate reflexes, abilities to find the nipple, latch onto the breast, and initiating breastfeeding. And methods of breastfeeding support are going to affect breastfeeding initiation, maternal infant bonding, and breastfeeding self-efficacy, or how well moms feel about their breastfeeding. And the physiologic process of breastfeeding should be supported by providers and undisturbed by unnecessary interventions and directions. In the absence of risk factors, healthy newborns should remain in uninterrupted direct skin-to-skin contact until breastfeeding is established. And providers should strive to remove artificial time constraints on breastfeeding initiation and create a supportive environment. And when needed, providers should offer encouragement and support to facilitating the breastfeeding dyad and following their breastfeeding instincts. So we really should let mom and baby take the lead. This is actually a much longer protocol that is sort of summarized here, but this is a protocol from the Academy of Breastfeeding Medicine on peripartum breastfeeding management for healthy mother and infant and term. And again, some of the key concepts. So it's all about antepartum education and screening for risk factors for moms before they come to labor and delivery. Intrapartum care should support breastfeeding initiation, and that may include things like doula care and consideration of analgesics in labor. That again, postpartum immediate skin-to-skin contact, 24-hour rooming in, which we'll talk about more, and lactation assistance are really important. And again, we're going to try to avoid interventions associated with breastfeeding complications like infant separation, supplemental feeding in the absence of medical indications, and to use things like soothers and pacifiers with some caution. Okay, so skin-to-skin care, otherwise known as kangaroo care, is really important. I've already said it about 4 times for early breastfeeding initiation. And if you want some data to back it up, it exists, right? So there was a Cochrane review. This is from 2016, which looks at early skin-to-skin contact for mothers and their healthy newborns. And it shows that skin-to-skin care promotes thermoregulation of the newborn, increases blood glucose levels, reduces physiologic stress, enhances successful breastfeeding, and improves maternal and infant bonding. You can even do skin-to-skin during a C-section. Now, rooming in. Rooming in, I know, can be a little bit controversial. And what I want to say is when we talk about rooming in or limiting infant and mother separation, we're not talking about abolishing the newborn nursery. We're not talking about saying that moms cannot utilize the newborn nursery if they choose. But we're talking about trying to keep, and parents or families that have expressed that they want to provide breast milk, trying to keep moms and babies together as much as possible in order to facilitate those early frequent feeds, right? I'm going to say it again. Early frequent feeds are really, really important for breastfeeding initiation, getting transitional milk to come in. And, sometimes what can happen if you separate mom and baby, or baby gets a formula supplementation and mom doesn't stimulate her nipples either by hand expression or pumping or some other form while baby's getting that bottle, is you can delay the milk coming in, right? So that's what we're talking about with rooming in. That's why it's really important. And there's also Cochrane reviews from the same year on looking at rooming in for new moms and infants. And it shows that, the rate of exclusive breastfeeding prior to hospital discharge is about 86% in families that room in versus 45% in separate care groups, which is a huge difference, right? And the difference in the number of daily feeds was 8.3 versus 7, which again, like I said, those early frequent feeds are really important. Getting another 1.3 feeds in per day actually probably makes a big difference. Now, there wasn't a difference in exclusive breastfeeding rates at 4 months. So, rooming in doesn't necessarily impact, total duration of breastfeeding, but it does seem to be really important in initial breastfeeding. And again, we want to try to avoid non-medically indicated supplemental formula. Again, what I'm saying, non-medically indicated supplemental formula. If formula is needed, it should be given. Again, we're not trying to ban formula, but we're trying to avoid it when it's not medically indicated. So early non-medically indicated formula supplementation, has been shown to decrease breastfeeding duration in multiple studies. I just put a couple from Journal of Pediatrics in the last 10 years or so on the slide, but there are many, many more that demonstrate the same thing. I also pulled this article from JAMA Pediatrics in 2019, which is actually an RCT, and it was looking at the effect of early limited formula on breastfeeding duration in the first year of life. And part of why I like this article and part of why I pulled it is because in this particular trial, all of these babies who got early limited formula, which was a 10 milliliter supplementation, I think, after each breastfeed, had a medical indication to get it. And what they showed was that there were differences in the duration of breastfeeding at 6 and 12 months. I think it was around like 76 to 66% in the babies who got the formula supplementation were about a 10% difference at 6 months. And at a year, it was 49% and 28%. So a bigger difference at 12 months. Now that was not statistically significant, partially because they had some attrition, especially at the 12-month follow-up, and the numbers were small. But, the way I sort of interpret this is in two ways. One, it seems that even medically indicated formula supplementation may have some impact on, long-term duration of breastfeeding. But at the same time, if you have a family that their goal is to breastfeed and they have a medical indication for formula supplementation, I think we should still be very encouraging to them that it does not mean that they cannot breastfeed, and they cannot breastfeed for as long as they want to, or what their breastfeeding goal is. So again, if formula is medically indicated and donor breast milk is not available, we are by no means advocating for withholding that. And, what does ACOG say? So, ACOG tells us that enabling women to breastfeed is a public health priority. And they advocate for the WHO's 10 successful steps to successful breastfeeding, which we're going to go over. The 10 steps approach is also adopted and utilized by the Baby Friendly Hospital USA program, which I think many people are familiar with. Okay. So what are the 10 steps? So the first step really is all about hospital policies, making sure that we have development of written policies, that we are trending our data and seeing if we're adhering to our policies, and avoiding any promotion of a particular infant formula brand, bottle, etc. Step number 2 is all about staff competency. So it's on us to train our staff to support mothers to breastfeed. And step 3 is really about what's going on in the prenatal care. So helping to prepare moms to breastfeed before they get to L&D. Step 4 is care right after birth, right? So skin to skin, I'm going to say it again. I'm going to keep saying it. Skin to skin contact, helping moms initiate physiologic breastfeeding right away is really important. 5, we're going to continue to support mothers with breastfeeding in the hospital. So again, this is giving them anticipatory guidance, lactation support, helping them troubleshoot common breastfeeding problems. For families that either need to supplement for medical indications or who choose to supplement, step 6 is all about making sure that families are able to supplement and do so safely. Number 7 goes back to that rooming in concept, right? So we're trying to keep breastfeeding dyads, mom and babies that are planning to breastfeed together as much as possible to enable them to feed as frequently as they need to. 8 is looking at responsive feeding, right? So back to those feeding cues we talked about several slides ago, making sure that moms know what those feeding cues are and not limiting how often they're breastfeeding and how they're responding to those cues. 9 is about bottles, teats, and pacifiers. So, supporting breastfeeding moms about what are potential risks of using pacifiers. Again, really one of the concerns is just masking some of those early feeding cues. And then 10 on discharge, making sure that there's support in the clinics and in the communities for families who are desiring to breastfeed. So these are just the steps laid out 1 through 10. I think part of what we're doing with the breastfeeding task force is looking critically at our current hospital practices. And I think, quite frankly, we don't do any of the steps consistently right now at Rutgers Robert Wood Johnson. So lots of potential areas for improvement. And we are absolutely going to be incorporating the 10 steps to success in our breastfeeding initiatives moving forward. So what are we doing here at RWJ? So we created the breastfeeding task force, of which I am the chair of right now. And we have representatives from obstetrics, peds, nursing, lactation. A plug for anybody else, if you're interested, please reach out to me. But some of our objectives are to develop protocols for best breastfeeding practices on L&D and postpartum. We want to do staff education and training. We're going to trend data on adherence to our new protocols. So if there are any residents or medical students out there who need a quality project, I've got a job for you. And our overall goal, right, is to improve breastfeeding success because we know it's important for our families. On the prenatal care side, we're working to expand the lactation classes before and after delivery. And we already have in-person classes that are now happening at RWJ Fitness and Wellness. So those have resumed after a pause on in-person classes during COVID. And we're also incorporating breastfeeding education in the clinics and as part of prenatal care. Some clinic initiatives that are going on. So first, I want to give a huge shout out to Dr. Montero and the Chandler Clinic because they are already working to incorporate breastfeeding education, breastfeeding materials, and signage at Chandler, and are going to be starting lactation support groups. So they are way ahead of the curve. Kudos to them. Also exciting developments in the high-risk clinic in the hospital are that we recently were awarded a grant to start a centering pregnancy program in our high-risk patients, which is also going to include a lot of breastfeeding education. On L&D, right, skin to skin, I'm talking about it again, but we really want to make it standard that in uncomplicated deliveries where mom and baby are doing well, baby will be skin to skin with mom immediately after delivery and stay there for that first hour, for that golden hour after birth, right? That means that if you're an OB doctor, you might be repairing someone's perineum with the baby on their chest, delivering the placenta with the baby on their chest. This is standard care in many hospitals across the country. Many of our providers that I've spoken to have done this at other places. Some people already do this now anyway, but we want to make it standard practice. For our nursing colleagues, it means that some assessments are going to need to be done on mom, and it means that some things may have to wait until after that first hour. So we may not weigh baby right away. Vitamin K or erythromycin may not happen before that first hour, but we really want to have mom and baby together for that normal early physiologic initiation of breastfeeding. We are going to be documenting feeding preferences in the EMR. We're already doing this, but we're going to make sure we keep doing this. And another new change is that admissions to the newborn nursery, instead of the baby being taken out of the room and into the nursery for assessment, are going to start happening at the bedside on L&D. Postpartum, again, feeding goals are going to be part of the standard nursing handoff of care. We want to make sure that everyone is aware of what a family's feeding intentions are. We're going to be doing couplet care, which I know we've been doing some already, but again, making couplet care standard practice, which means that a mom and baby will have the same nurse. So there's not additional, there doesn't need to be additional communication between more care providers about what the feeding plan is. Formula will still be available on request. Again, no one's banning formula, but we're not supplying it in the bassinets. And so families will have to ask for it, and it'll be an opportunity for families who have expressed that their intention is to breastfeed to do some education and anticipatory guidance on why maybe formula might not be needed at that time. And again, we're going to be supporting rooming in, or basically trying to keep mom and babies together as much as possible for dyads that plan to breastfeed, and really promoting and supporting feeding on demand. So, breastfeeding really is a team sport, and the University of Louisville Cardinals have won a national championship in recent memory. I have faith that they can get it together and win one again. And I have faith in us. I work in the hospital with all the people on this call, and I know that people care about our patients, and everyone, wants to do great things. And I think we really have an opportunity here to improve our breastfeeding rates, not just to make our numbers look better, although, admittedly that's important, but to really support our families who want to breastfeed achieve their goals. I, of course, had to include a picture of my own breastfed nugget. He's much bigger now. He was, I think, about 3 months old here. And I don't have any great breastfeeding pictures of myself, which I kind of regret now, but I'm pretty sure we were either about to breastfeed or just breastfed, because I'm wearing one of my breastfeeding covers in that shot. Here are the names right now of the people who are currently involved in the breastfeeding task force. So I thank all of them for their support. We've met 3 times now and have an ongoing monthly meeting. Again, if there's anybody who's interested in joining us or would like to be involved, please feel free to reach out. We're always happy for all the help we can get, because really today, the most important thing, the biggest reason I wanted to give this talk was because I'm asking for help. I'm asking for buy-in. I'm asking for people to be excited about breastfeeding. I'm asking for people to want to do the work with us, because I think this is really important. And I think we have such an opportunity to improve our systems and our practices. And I hope that, you'll all be as excited as I am. So we have some time now for questions. Like I said, Dr. Schaefer is on the line and available. I know we also have some Dr. Yavelberg from pediatrics and some nursing representatives. So I'm more than happy to take any questions, or if people have other questions for other people on the call, that's great too.
Thank you, Dr. Patrick. Thank you for that excellent talk. Naina Shah, our finest resident, has a question.
Hi, Dr. Patrick. Thanks for your presentation. I have 2 questions. One, I think, is one that a lot of the residents were probably wondering as well. Do you have a favorite app or website that you use when you were checking the safety of certain medications in breastfeeding? I would love to have that in my pocket.
Yeah. No, my favorite one is something called Infant Risk.
Okay.
It's from Texas Tech. I think you do have to pay like $10 for it. I forget exactly how much it is. Right. I'll tell you what, if the residents want it, I will sponsor the residents to download the app. So just let me know.
My other question is just a bigger question. It's just, I was just wondering if you had looked into it all, the other hospitals in our health system / other hospitals in New Jersey or just around the country who have better breastfeeding rates than we do in their hospitals, if there's anything specific that they're doing that works really well for them, or anything else that, we should be doing. We're just curious.
Yeah, that's a great question. So first I want to mention Dr. Schaefer, and I saw Dr. Rosen put some other great resources in the chat for checking breastfeeding compatible meds. So please, those of you, look at those as well. So yes, so I will say we have seen protocols for at least one hospital in our system that has breastfeeding rates in that 30% area, and they're basically following the 10 steps. That's basically what they're doing in their protocols. Now, I'm not in the hospital there, so I don't know, how good their adherence to their protocol is. But I think it seems pretty clear that if we also implement the 10 steps, we should see an increase in our breastfeeding numbers, hopefully, relatively quickly. I think it's fair to point out, though, that nobody in our system is meeting the Joint Commission metrics, so there's probably more work we can all do. And, we're always open to ideas and brainstorming to see how we can make those numbers even better.
I see that Dr. Sideram has her hand up.
Hi, Dr. Patrick. Thank you so much for this talk. It was excellent. I actually have two questions for you. My first question to you is, like you mentioned, there's a lot of concern about that milk not coming in that first day or so. And a lot of women end up being worried that they're just not going to be making enough and quote unquote are underproducers. I was wondering if you had an idea of what that true number of patients that actually don't produce enough milk is. And the reason I bring it up is because I imagine it's actually quite low, and I would love to be able to tell these patients, like, no, your concerns are actually, I understand where it is, but it's probably a lot less of a risk than you think it is. So I was wondering if you actually had a number for that. And then the other question that I have for you is, do you know of any community-based groups? Like, a lot of breastfeeding, I think, in cultures are based on moms and aunts and everyone sort of teaching, new moms how to breastfeed. And then even in this current day and age on Facebook, for example, for physician moms, they have Dr. Milk, which I don't know if you used yourself, but was an incredible resource. So I wonder if you know of any resources like that that are kind of geared towards the community and really creating that community for the mom.
Yeah, so to answer your first question, I honestly don't know off the top of my head the number. I agree. I think it's actually probably very small. And if Dr. Schaefer or anybody else knows that number, please feel free to jump in.
I think it's around 5% have impaired lactation for a variety of reasons, but some of that can be overcome with some of the things we talked about as well. So, but yeah, I think it's around 5% have impaired lactation.
Yeah, thank you so much, Dr. Schaefer. I had a feeling you would know the answer to that question. And then you may also want to jump in as far as, community support and resources. And I actually had intended to include a slide on this and ended up having to cut it when I realized I might go over time last night. But there are several resources out there. So Zip Milk is a website you can use to look up lactation support in your area and potentially even buy your insurance. There's La Leche League. There is websites like Kelly Mom. The Stanford has the Stanford breastfeeding videos online that are free for anyone to use. Dr. Schaefer, you can jump in if you have other good resources.
Those are all really great. Yeah, healthychildren.org is AAP's breastfeeding. They have information, and then Breastfeeding USA as well. But I agree with you. Kelly Mom is good. The Leche League is excellent, and Zip Milk is a good resource. Yep, and WIC, of course, as well.
Mm-hmm. Yeah, and WIC. And that's another thing. Many of our patients that that are publicly insured can get lactation support through WIC, and they don't always know that.
Hi, I'm
I
Dr.
see that
Bakshi.
Dr. Bayat has her hand up.
Dr. Bakshi.
Dr. Bakshi, just raise your hand, although we're kind of short on time, but several other people have raised their hand. So Dr. Bayat is next.
Hi, good morning. Thank you so much. That was such a wonderful presentation in its area I'm also passionate about, so I really, really appreciate it. I have one comment and then one question for you. So my comment is about, I recently had a patient who I delivered who had choreo, and I was really surprised to learn that when the baby was in the NICU, the mom wasn't allowed to go to the NICU at all. So for the first 24 hours, she wasn't able to, see or meet or hold her own baby, which I thought was a little bit crazy because they have a rule that you have to be 24 hours afebrile before a mom can go to the NICU, which I understand for contagious things, but for something like choreo, really boggled my mind. And I think that that's a big barrier that we have to work on. My question is, so in most things in medicine and especially in OBGYN, we know that our patients of color and in particular Black women and infants have, disproportionately worse outcomes. And from my understanding, breastfeeding rates in Black women and infants is also lower than their white counterparts. So I'm just wondering, in our own institution, is that data that we're tracking? Like when we look at our breastfeeding rates, are we looking at how that rate compares in our patients of color versus not? And do we have any initiatives that we can do to address that own disparity within our own institution?
Yeah, no, those are great. So, for your first comment, I agree that there are potentially areas that we can work with pediatrics on protocols and improving, moms being able to breastfeed, sooner, especially with NICU babies. Again, I wish we had more time today to talk about all of the potential initiatives. Right now, we're focusing on mostly what we can control on L&D and postpartum, but your comment is salient and definitely something that we're also aware of. And then your second question about how we're tracking the data. As of right now, we just have our total overall numbers. Quite frankly, because they're so low, I suspect that they're pretty low across the board. But one of the things that we're looking at as we start to trend data, and again, plug for residents who want a quality improvement project, is to start kind of getting more granular data and understanding more of our own trends here at the hospital. I will say I didn't have time to include it because, again, there's so much you could talk about, but there is, good data out there looking at the 10 steps, and especially hospitals that have implemented the baby-friendly hospital protocols, where they've shown, in particular, at-risk populations and populations of color, where they've seen particular strides in improvement in breastfeeding rates with some of these initiatives. And so I'm hopeful that this will be good for all of our patients.
I see that Dr. Ham has her hand up, and I think this is probably going to be the last question since we only have 1 minute left.
Yeah, great talk, Dr. Sweat-Patrick. And being on the front line with a lot of these moms and seeing how Robert Wood Johnson operates, I really, really feel if we are as committed and passionate as you are, that we need a couple more resources. We need more personnel. I think that maybe possibly a lactation consultant on labor and delivery to come in and help take care of these moms when you're trying to get the initial postpartum breastfeeding. More lactation consultants for more hours. I feel like I see the lactation consultants, running around, and my patients will ask, where's the lactation consultant? I said, well, they're very busy and they're taking care of the discharging patients first. But maybe if we had more resources to help the lactation consultants and more personnel to be as focused on this initiative as, we're asking the patients to be. So to put resources and put money to this problem with personnel that can help us, especially when a nurse is taking care of a postpartum hemorrhage in labor and delivery. Trust me, I know we want this to be our first thought, let's breastfeed, but it's not their first thought. So maybe having additional personnel on labor and delivery who comes to see the patient periodically while she's laboring, and then discusses like breastfeeding and what you're going to do when she delivers, and skin to skin, like having that extra personnel would be super helpful.
Yeah, no, I agree. More personnel would always be great if we have the luxury, and if someone has the money to give me for that, I will happily accept it. I think short of that, part of what we can be doing in the meantime is more education, antepartum, during labor, giving people anticipatory guidance, facilitating that early golden hour without a ton of intervention, honestly, and just making sure patients know what to expect, which a lot of that I think is going to need to happen before people get to L&D, because I agree, once you're there, the staff is busy, we have a lot going on, and we can't all do it by ourselves. But I'm hoping if we pool our collective resources and efforts, again, physicians, nurses, nurse midwives, postpartum, labor and delivery, everywhere, that we can make a real impact for our patients. But your point is well taken.
Thank you, Dr. Patrick. Thank you so much for this excellent talk. Everyone, I'm sorry that there are more questions in the queue and we didn't have time, but I think that that's a testament to how passionate we all are about this important topic. So we're going to have to end it here. I wish everyone a fulfilling and productive day.
Thank you, everyone, for your attention.